Good afternoon, everyone. It's always a great pleasure to be part of the prestigious annual conference of the Jordanian Surgical Society. The title of my talk is The Impact of COVID-19 on Thyroid Cancer Surgery and Adjunct Therapy, a Jordanian Experience. I have nothing to disclose. COVID-19 is a public health crisis that has profoundly altered the way medical and surgical care is delivered. Countries around the globe had a variable initial response to the crisis, ranging from imposing massive lockdowns and quarantine to surrendering to herd immunity. As for the health sector, medical and surgical care was restricted to COVID-19 and emergency cases. The government of Jordan, between the March the 17th and May the 20th, imposed massive lockdown and applied healthcare restrictive policies. Our study is a retrospective cohort study specific to this time period, in which 12 patients, all of which were cases of papillary thyroid carcinoma, were scheduled for surgery. Surgery was in the form of total thyroidectomy with or without selective compartment-oriented functional neck dissection. And as all these cases were cases of differentiated thyroid cancer, they were destined to adjunct therapy in the form of radioactive iodine ablation of remnant tissue, adhering to the most recent clinical practice guidelines. As we all know, there are two ways of administering radioactive iodine. The conventional way, in which radioactive iodine is administered 3 to 4 weeks following thyroid hormone withdrawal, targeting a TSH level of greater than 30. Alternatively, it could be administered the rapid way, in which radioactive iodine follows exogenous stimulation using recombinant TSH, also known as thyrotropin alpha, which rapidly achieves a TSH level greater than 100. In Jordan, the preferred or routine way is the conventional way, rather than the rapid way, which, as the latter is most costly and not covered by insurance companies. The primary outcome of interest was to assess the impact of restrictive policies applied by the Jordanian government on the safe and timely delivery of surgery and its adjunct therapy. We also reported the financial and psychological impact of deviating from the routine method of administering radioactive iodine ablation therapy. The psychological impact of delaying radioactive iodine ablation therapy was assessed by the Hamilton Anxiety Rating Scale, also known as the HAM-A, in which ultimately patients are stratified according to their level of anxiety into 3 groups: mild anxiety, mild to moderate anxiety, and moderate to severe anxiety. Data collection and analysis were performed according to institutional guidelines and the ethical standards of the Helsinki Declaration. There were 9 females and 3 males with an average age of 56 years and an average tumor size of 4.4 centimeters. Total thyroidectomy was performed in 11 out of the 12 cases, as one of the cases was a redo case for recurrent papillary thyroid carcinoma. 7 patients underwent bilateral central compartment neck dissection and 5 cases underwent lateral compartment functional neck dissection. All surgical procedures were performed as scheduled on time and with no delay. And this is because we followed a safe and comprehensive surgical strategy during the COVID-19 period, which we described and was published in Updates in Surgery and was reported here in this conference earlier by my colleague Khalid Al-Umar. As for radioactive iodine ablation treatment plan, we can see that there was some alteration in the radioactive iodine ablation management plan according to the time period in which the patient was operated upon. 7 patients were operated in March. 6 out of the 7 patients operated in March had to change from the conventional method of radioactive iodine ablation to the rapid method, as radioactive iodine was or would have been not available 3 to 4 weeks later because of the lockdown of international borders of the government of Jordan, even for commercial purposes. One of the 7 cases, he opted to delay receiving radioactive iodine ablation therapy until it was available once again. There was only 1 patient who was operated in April, and that patient again opted to delay receiving radioactive iodine ablation therapy until it was available. In May, 5 patients were operated, and all 5 opt for the conventional method, as radioactive iodine was available in May due to opening of international borders for commercial purposes. So what do these results mean? This means that 6 out of the 12 patients, or 50% of our cohort, had to pay an additional extra personal cost of 100 or 1000 JD for thyrogen or thyrotropin alpha, which was not covered by insurance companies. And this also means that the 2 patients who opt to delay receiving radioactive iodine ablation therapy were classified as having mild to moderate anxiety according to the HAM-A scale. It is said that the past is a place of reference, not a place of residence, and the past is a place of learning and not a place of living. So what lessons do we learn from this small cohort? That although maintaining the infrastructure of healthcare systems and their ability to accommodate for a potentially overwhelming increase in critical care needs is important, providing safe and timely surgical care is considered equally important, adhering to the motto of medicine, primum non nocere, or first do no harm. Secondly, surgical treatment plans for cancer patients are considered essential elective procedures, and cancer patients should be regarded as a person under a special form of stress. There is mounting anxiety, which may at times increase to where the individual is disorganized. Therefore, undue delay in delivering essential surgical care has a potential for an additive detrimental impact on mental health. Thank you very much.
عادي أنا بدي أروح أنام.